السلام عليكم، معكم شفق ميديكال مختصين بالعلاج في تركيا. تشاهدون اليوم الحلقة الثالثة من السلسلة الأسبوعية شيقة مع البروفيسور التركي علي زيرح، الخبير في علاج الباركنسون والاضطرابات الحركية. في هذه الحلقة يشرح البروفيسور الامراض المستعصية المتعلقة بالدماغ من غير الباركنسون كالشلل الرعاش، الMS وأمراض أخرى التي يمكن علاجها بعملية التحفيز العميق للدماغ. ونسأله في المقابلة خطوات ومراحل وكيف تتم عملية التحفيز العميق للدماغ. نترككم الآن للمشاهدة. أولاً بروفيسور، ما هي الأمراض التي يمكننا علاجها بعملية التحفيز العميق للدماغ؟
The main area now is the movement disorders, not only Parkinson's. There are some diseases called as dystonias, like involuntary contractions in the muscles in the body and involuntary movements. In dystonia patients, if the medical therapy is not sufficient enough, DBS surgery also helps to treat dystonia patients. And the other movement disorder we have very well is essential tremor or positional tremor. Let me explain the difference. The Parkinson's patients shake when they have a rest, like the arms here or in armchair or walking and in the body side. And if you ask Parkinson's patients raise the arms, usually tremor stops. But the other tremor, named as essential tremor or positional tremor, and sometimes it happens in the family members also, the patients do not shake in the rest, but when they try to hold something, when they try to write or drink water, they start to shake. So it's called as essential or positional tremor. So, and actually it is more frequent in this community than Parkinson's, even 4 times, 5 times, but it's not known very well, or the patients do not go to doctors for treatment very frequently. So DBS also helps the essential or positional tremor very well. So in some cases, like multiple sclerosis patients, MS patients, following MS problems, there might be some other tremors. And also DBS can help tremors of MS patients, but not the disease itself. So we have to clarify that. We cannot, and we are not treating MS with DBS surgery, and unless the patient doesn't have severe tremor, that's not the indication. But only MS tremor, the tremor only, can be helped with DBS surgery also. These are the main goal of DBS surgery for now. DBS is used also in some psychiatric cases, in severe obsessive compulsive disorders, and also in severe depression cases. Some clinics in US and Canada are working on them, and if we put electrodes in the brain and give some electricity, we know that we can help these patients. But for now, there are various targets they are working on, so there is no one single target generally agreed, and that's why I'm waiting the results of that. I'm not using it now.
الآن بروفيسور، نريد أن تشرح لنا كيف تجرى هذه العملية للمريض وكيف تتم عملية التحفيز العميق للدماغ.
This is a kind of awake surgery. At the beginning, we put a frame on the head of the patient for calculations at the bedside in the room, and only for injections and needles the patient feels for putting the screws and fixing the frame. And then after putting the frame, we'll take the patients to the MR studies, get the image, and from that image, we are generating that patient's specific brain maps to find the exact locations of the coordinates of the target in the brain, which is called as a theoretical target. And then we'll take the patient for the beginning of the surgery. So like not everybody's nose, eyes are the same. So the real coordinates in the brain actually are not exactly there, even with advanced calculation techniques. So we need to do physiological mapping of the brain, then try to find the cells responsible for the disease. Because the rule of the game is trying to find a 3 millimeters in diameter structure in the brain, and we don't have a right to go one side or below or up. So for the success of that, we use microelectrode recording and stimulation technique, which means that we are advancing a 2 micron tip tiny electrodes in the brain, and with hooking it up with very expensive technological devices, we could be able to one single cell's electrical activity in the brain, and we can map it. So every single cell has a language in that area, and if you know that language, and if you try to reach that language, it looks like you are traveling in Europe. So if you know that language, you can understand which country you are in, unless you faced up with a tourist or something like that. So this technique also helps us to stimulate the brain in an awake patient, and with a limited, reduced level of, we can limit that spread of the electricity, for example, in 80 microns. And we can question the responses of the patients to that stimulation. So with recording and stimulation, we can do physiological mapping in the brain, and we can directly put the exact locations of the cells which are responsible for the disease with an 80 microns discrepancy. We call them as kinesthetic cells. So the one side of the brain rules out the other side of the body. So when we're mapping the left side of the brain, we are gathering information the right side of the body. So every single trajectory's journey, we can listen to the cells, and we can find the, for example, cells responding to joint movements, active or passive, or some actions. And also the patient tells us after end of each trajectory what kind of feeling he has. And he can say that now arm is better, the previous one was better, now my leg become better. And then we can match the patient's reports, feelings, and also the awake surgery's cell recordings. Then we can find exactly where can we put the electrodes in the brain, which is actually the precious thing to bring us the success. So we have to, and we need to do, that microelectrode recording and stimulation mapping on every single patient. So it's about 2 hours journey, 5 trajectories at least on both sides, and then we know where we are in the brain and where we are supposed to put the electrodes in the brain. And then under the scopy control, we put the electrodes in the brain, and then the brain surgery ends. We take off the frame, and our anesthesiology team puts the patient to sleep, because we are going to put electrodes, extensions, and device. This is the second stage. The awake surgery, brain surgery, lasts about 2.5 hours. And then patient goes to under anesthesia, like 45 minutes. Then we put extensions and cables and device, and the surgery ends. The end is actually the beginning, because we have to program the device. So 2 or 3 days later, at the beginning of next week, every single patient comes to our outpatient clinic, and we start to program the device. And it is roughly 3 weeks for every single patient, every single day. And after the 3 weeks, actually, our patients are getting graduated, and we send them back to their home country, wherever they are. If the patient is, our citizen, we would like to see the patient every 3 to 4 months. For foreign patients, we don't want to exceed 6 months, and we need to see them twice in a year to check the system, battery, and also the medications, because they need to be adjusted. Until recently, we used to put non-rechargeable devices because of the technology. For now, we could be able to put rechargeable devices. So with the company's claim, they can last up to 25 years. So we don't need to replace batteries now. The reason for that, the electrodes technology. In the last 2 years, we have a chance to use directional lead technology, which means that the electrode has not a rim electric disturbances capacity. It could be divided. So like the lighthouse projected beam, we can project the electricity in the brain in different areas with that technology, which is called as directional lead technology. So that helps us additional benefits for getting more life quality, getting rid of side effects, and also saving the battery life. So for now, with the advance of the technology, directional lead and rechargeable technology, and also MR compatibility has matched, And now we are using the latest technology. So our patients can go to MR controls, can be used directionally technology, and can have rechargeable batteries, and which is also very beneficial for us because it has been a long journey for DBS surgery. Years ago, we started just single polarity electrodes. For now, we have 4 polarity electrodes, and 2 of them we can have directional technology, which means second polarities can be divided in the brain with delivering electricity, and also the rechargeable technology, which is valuable for us.
تشاهدون في الفيديو القادم تجربة المريض جينكو من رومانيا، كيف كان قبل العملية ومشاهد أثناء العملية وكيف أصبح كذلك بعد العملية.